So before we get started, I wanted to give you a very brief introduction to our presenter. Dr. Meijer joined the Pediatric Neurology team and the Research Center at CHU Saint-Justine, Montreal, as a clinician researcher specializing in pediatric movement disorders last year, probably about a year ago, I think. And she first developed an interest in human genetics during her Bachelor of Science in Biology at McGill University. She completed a PhD in neurogenetics in the laboratory of Dr. G.A. Rouleau, director of the Montreal Neurological Institute at McGill. Dr. Meijer is one of the few pediatric movement disorder trained specialists in Canada, where she combines her knowledge in genetics and pediatric movement disorders to diagnose, treat, and study rare forms of pediatric movement disorders with a focus on dystonia and Tourette's. Now, without further ado, I will turn things over to Dr. Meijer. Thanks so much.
Thank you. I hope everybody can hear me. Welcome, everyone. I'm in Montreal. It's pretty cold out here today. I'll be presenting to you a bit of my knowledge about pediatric dystonia and catered for U.S. parents. So I'm going to talk about a lot of scientific things because I'm a scientist, but I also appreciate when parents are partners in medical care. So I think it's important that you have this information. And if you don't understand something, please ask questions because there will be a lot of information. So I'll just try to. I have no real conflict of interest to disclose. I've received honoraria for speaking from Allergan in the past, and for my fellowship, I was funded by the American Academy of Neurology, as well as a local scholarship named after Dr. Irma Levasseur. So I thank those funding agencies for giving me the opportunity to get my training in movement disorders. The objectives of this talk will go through these 5 questions, and Stephanie already hinted to me that for U.S. parents, the parts that you're most interested in are maybe points number 3 and 4. How do we diagnose dystonia? How do we treat it? And what's new in dystonia research? What's coming? So we'll tackle these questions one at a time. And so we'll start with the first one. What is dystonia? By definition, dystonia is characterized by the sustained or intermittent muscle contractions, which lead to abnormal movements or abnormal postures. Before, we had this diagnosis of 2 muscles that were antagonizing each other, but right now that's no longer retained in the definition. Dystonic movements are often patterned and twisted, and they may be tremulous. So that's really important because before there was a confusion about whether or not people with dystonia can have tremor, and now it's very clear that dystonia can lead to tremor. A very irregular tremor, but it can lead to tremor. And a particularity about dystonia is that it's often initiated or worsened when we're trying to complete an action, and that sometimes we have overflow, which means that another body part will also adopt a dystonic posture when we're trying to move with the dystonic limb. There's 3 phenomenons that come with dystonia. One of them is quite peculiar. It's called the geste antagoniste, or the sensory trick, where a voluntary action can actually diminish or completely correct the abnormal dystonic posture. Something called state of function, which is that when the dystonia can decrease or increase during an activity in another body part. And I'll show you 2 examples of that in adults because it's harder to get our kids to do these specific things for us. And it's harder for children to realize that they have these tricks that they can use. What's really important, I think, for parents to know is that dystonia can be triggered by different things. So by sleep transition, so awakening from sleep, tiredness, you must have all had that, noticed that, lack of sleep, cognitive tasks when we're trying to concentrate to do a task, emotional state, so very, very stressed out, or dystonia is usually worse, hunger, so being fasting, temperature, involuntary movement, or touch. So touch from someone else can trigger a dystonic posture at times. So I'll show you two examples. This is the first one. I don't think you're hearing the sound, which is not important. You see this lady has tongue dystonia and mouth dystonia. And when she puts a little pen or a syringe in her mouth, she's able to talk much more readily. This lady can use her hand to touch her forehead or the back of her head, and it stops the cervical dystonia, which is the pulling of the neck muscles. And this one I'll skip. So state of function, here you see a man who has dystonic posturing of his arm here in this area. I don't know, can you see, Stephanie, my hand, my little arrow?
Yes, I can.
Okay, perfect. So you see that this muscle here in this man is pulling, but then when he walks, he's completely straight and there's no muscle pulling. So that's state of function. When he's doing another task with another muscle, we don't see the posturing as much. And patients often develop these tricks on their own when they get to know their type of dystonia a little better. I put this in there because we often throw out a lot of words. So in addition to dystonia, there's many other movements that we can see in patients. We can see chorea, myoclonus, spasticity. And what's also important to realize is the last point down there is that spastic dystonia is a term that we're using more and more. Before, we would either try to categorize something as dystonia or spasticity. And we realized that especially a lot of cerebral palsy children, so CP children, they have a mix of both. And the medication changes a little bit according to whether it's just dystonia or spastic dystonia. So it's clinically a very important distinction to make. This is a big table. And the point of this table that I want to make with you is that when we see dystonic patients, this is kind of how we try to classify the patient. So what age did it start? Which body distribution? Is it just one body part? Is it the entire body? What's the temporal pattern? Was it sudden onset, gradual onset, etc.? And then the second part is what are the causes? The second classification is based on cause. What's I think really important and I want to underline is that in the body distribution, we often talk about focal, segmental, or generalized. And focal just means one specific body part. And generalized is what we see more in our children. And this is an important difference because the medications will depend on whether or not there's focal or generalized dystonia. The second distinction is that when we describe dystonia, we determine whether it's isolated dystonia, which means that your child only has dystonia and no other neurological problem. Combined dystonia is when we have dystonia with another neurological problem. And then a third term, which we call complex dystonia, is when there's dystonia, other neurological problems, and other problems altogether. So liver problems or vision problems, etc. To give you some examples about focal dystonia, we can have dystonia of the neck, which is called cervical dystonia, blepharospasm, it's the eyes, oromandibular, which is this drawing. You see the man squints his eyes and he opens his mouth really wide. That's oromandibular dystonia. You can have laryngeal, which is dystonia of the vocal cords, Reiter cramp, I'll show you an example later, and then really arm or leg dystonia. Here is an example of a child with Reiter's cramp. You can see that she keeps turning the page around because her hand gets all cramped up while writing. And you also see that she has a posture of having to lean in to the paper to be able with the dystonic posturing. The other thing that you just saw here, I'll play it again, is that you see little jerks that she has. That's the myoclonus jerks. So this girl has myoclonus dystonia, which is one of the genetic subtypes of dystonia, of combined dystonia. This man has craniocervical dystonia, so the face is involved as well as the neck. You see here that he has flexion of the head. His head is twisted and flexed to the side. And he uses his sensory trick by holding his neck in the hopes of having less posturing. He has trouble speaking. You can't actually hear his voice, but he has a really hoarse voice because his vocal cords are involved as well. So he has DID6, which is more common in the Mennonites. This example I wanted to show you because dystonia can be tremulous. So this is an older man and he has neck dystonia, cervical dystonia, and you see this tremor that I wanted to show you in order for you to see that dystonia can be tremulous. There can be some shaking. So that's a quick overview of what dystonia is and what the characteristics of dystonia are. What causes dystonia now? So where does dystonia come from? Well, what we know so far is dystonia is a problem in the basal ganglia, which include the putamen, the globus pallidi for sure, which are the deep parts of the brain, as well as the thalamus, and the messages that are passed on to the hindbrain, so to the cerebellum. Many people are studying this to try to better understand the exact mechanism, and it's not completely clear yet. But what we know is that there's probably too much excitation, so some cells are over firing too much, and then there's not enough inhibition, so not enough decrease of the messages around this overly excited part of the brain, this part of the brain that's hyper excitable, basically. Sorry, I'm not saying it right. So that's basically what we think is happening in dystonia. And another way of seeing this is a more complicated graph, is that we think that there's two types of on the completely mild side of dystonia, we have things that are called task-specific dystonia. So we know in golfers, for example, they have the yips. By making a certain repetitive movement, they can develop dystonia. So as, for example, musicians that play the violin, they can develop dystonia in their arm that keeps doing the same movement. And then we have the more genetic childhood onset dystonias. And we think that it's really an interplay between use as well as genetic predisposition, or how your cells and your basal ganglia are malleable to change over time, which we call plasticity. And the two neurotransmitters, the messaging molecules, the messengers in the brain that are important in dystonia are dopamine and acetylcholine. There are more, but those are the main ones. And that's important to realize because when I'm going to talk about the medication, our medications have an effect on these molecules specifically. So in terms of causes of dystonia, there's many causes. So on this side here, we see all sorts of genetic causes, and I'll talk about some of them. But the ones that are most common are drug-induced dystonia. We see this a little bit more in adults, but people who are taking anti-nausea medication, neuroleptics like Seroquel, quetiapine, risperidone, those things can all cause dystonia. And a major cause of dystonia are perinatal cerebral injuries, so cerebral palsy or kernicterus, which means jaundice at birth, severe jaundice. We know that many of the dystonia forms are genetic. So this is a quick, diagram of the types of genetic forms that we now know and have identified. And why I showed this one is because it's important for us to know as a clinician whether or not the dystonia is generalized or just one part of the body, because that helps us determine which gene your child potentially might have a mutation in, and whether or not it's associated with other clinical features, for example, slowness or myoclonus, that will give us hints as to which gene which gene might be mutated in your child when we suspect genetic dystonia. Through the identification of genes, we've so far researchers have so far pinpointed several pathways. So we know that dopamine pathway is important, and then if we have dysfunction of the dopamine pathway, we can develop dystonia. We have heavy metal accumulation as one of the mechanisms, and we have mitochondrial dysfunction, which are the energy providers in our cells. So how do we diagnose dystonia? The approach of a neurologist to dystonia is, first of all, to ask, is this dystonia? So I look for all the features that I mentioned to you in the beginning of the talk, and I determine whether or not those criteria are filled. I do a really good history, including a good family history, making sure that there's no medications that have been used in the past that could have caused the dystonia. I do a thorough neurological exam. Usually most people with dystonia will get an MRI of the brain and sometimes of the spinal cord if we think it's indicated. And then a lot of blood work to look for metabolic signs, to look for certain specific diseases. Initially, patients with dystonia would often get a lumbar puncture if we couldn't find the causes through an MRI. But nowadays, with genetic testing, sometimes in certain centers, it's very center dependent, we avoid the lumbar puncture, which is a little bit more invasive. It's more, and do genetic testing right away instead of doing the lumbar puncture, which can give us more of an idea of which pathway is involved when we do the lumbar puncture, as opposed to a genetic test, which can give us mutations, but sometimes we're not always sure if the mutations are actually the ones that are causing the disease. So I put this up there, but there's tons of blood work that we do to eliminate a whole series of diseases. And all neurologists, this is not a workup that has to be done in every single individual. It really depends on the clinical suspicion of the neurologist, and then he'll do certain tests. What we usually do, and I mentioned it here, is that we usually try to test for all diseases, all types of dystonia that are treatable and that actually have a relatively easy molecule that we can easily give as a treatment. Which brings us to the next section. How do we treat dystonia? So the first thing, as I said, is we need to make sure that your child doesn't have a treatable dystonia, because treatable dystonia literally means that there is a molecule, a vitamin or something that can actually stop the progression of the disease and sometimes even improve the child tremendously. So the common ones are the ones that we know now more and more are, for example, ataxia with vitamin E deficiency, biotinidase deficiency, which you would treat with biotin, coenzyme Q10 deficiency, where you give coenzyme Q10, and the most commonly described one is dopa-responsive dystonia. So here I'll give you an example of dopa-responsive dystonia. This is a girl who at a young age had dystonia. We see posturing of her legs, of her trunk when she does, and when she tries to do the rapid movements of her hands, you see her trunk pulls and her legs get worse. She has this kind of dystonic gait with the two walking with her 2 feet inward and a little bit stiff. Here you see she's walking much more fluidly because she is taking levodopa right now. So you see great improvement of her walking, and this is at an older age where you basically don't even realize that she has dystonia. So the majority, almost every child with dystonia that I see with a normal MRI will get a dopamine trial, a levodopa trial, to see if they can be a levodopa responsive dystonia, unless we already know the genetic type of dystonia and we know that it doesn't respond to dopamine. The dopamine pathway is really important, so I'm just showing you that here. These are the different molecules in the dopamine pathway that can be mutated in dopa-responsive dystonia. And the link that I wanted to make in this diagram also is that these pterins are all also important for making serotonin. So if there is a problem in any of these genes, we also get lower serotonin, and people are trying to understand whether that may explain why certain forms of dystonia are more associated with depression or anxiety. So this is an example of ataxia with vitamin E deficiency. It's more of a gene known for ataxia, but these children often are also dystonic. So we see he has a dystonic head tremor with cervical dystonia here, and he also has, you see his shoulder is more elevated and his neck is slightly posturing. When he walks, you see that clearly also. And you'll see his brother in the next videotape. He has posturing of the hands and fingers, so that's dystonic posturing. And they, when you treat with high dose vitamin E, you can actually stop the symptoms from progressing. Unfortunately, you can't actually improve them much from back to normal, but you can actually stop the disease from progressing. And sometimes they have improvement as well, but never to completely cure all symptoms. So this is the important part for the parents, I think, to clarify. What I just was presenting were forms of dystonia where there's actually a treatment that fixes the problem. In most children, that's right now not available. And what we do is we treat the symptoms. So we call that symptomatic treatment in dystonia. And the medications that are known so far are trihexyphenidyl, which is Artane, the commercial name. Benzodiazepines, there can be many. There's clonazepam, which is Rivotril in Quebec. I don't know, I guess the names are the same in Canada. All over Canada. We have diazepam, Valium, and so forth. And they all work the same, except that they have slight differences in their duration of treatment. So, and also I tend to prefer clonazepam because it has a longer duration, but depending on the doctor, they might have other preferences and molecules that they know better. There's baclofen, clonidine, gabapentin, levodopa, and tetrabenazine. And I don't know if I put it here, but trihexyphenidyl is an anticholinergic, so works on acetylcholine, blocks acetylcholine. Benzodiazepines, baclofen, and gabapentin are GABA agonists, so those are the inhibitors of the nervous system. And levodopa, it's not really clear how it works and how well it works because the tetrabenazine is actually a blocker of dopamine, so it's not really clear why we can have benefit from levodopa, but unless you're a dopa-responsive dystonia where you have excellent response. It's really important to realize that all these medications were not studied in very large studies for dystonia. We know the medications very well. We know their side effects really well because they've been studied for many other conditions. So in spasticity, clonidine for blood pressure, for example, gabapentin for pain. So these molecules have been used in many people for many years, and we know their side effect profile really well. We know the dosage really well. But unfortunately, in dystonia, and especially in pediatric dystonia, there's very few studies that actually support that these medications work in dystonia. Clinically, and if you ask groups of experts, there's the article that I mentioned here from Dr. Feelings in the bottom, mentions that the expert committees do think that this works, that trihexyphenidyl and the benzodiazepines are really the go-to treatments in dystonia, and then the others are added on depending on the cases. Aside from medications by mouth, we have other options. Actually, that's interesting, I forgot, but we have deep brain stimulation, which I'm going to talk about. Intrathecal baclofen, which is baclofen that we can take by mouth, but through a pump in the spinal cord. And physical therapy and occupational therapy, very important, and psychology. For little kids, psychology is maybe less relevant, but I think for the older children and teenagers, sometimes it may be useful. As I said, anxiety, depression can make our symptoms worse. What I forgot here, I don't know why I forgot it, is obviously botulinum toxin, of which there's many different types in Canada right now. And I'll talk in the next diagram about when we decide to use which one of these molecules.
Dr. Meijer, can you hear me?
Yes.
Okay. We have a question that's come in.
Okay.
The question is, how does levodopa, carbidopa work?
Yes. Great question. So how does it work for dystonia? It's not very clear. For dystonia at large, it's not really clear. Basically, we have dopamine as a neurotransmitter in the brain, and levodopa is the precursor to that. If I go back to my little diagram here, this is levodopa. This is the Cinemet that we give to our children. So basically, it increases the amount of dopamine in the system. All right. And when in dopa responsive dystonia, we have mutations in these genes and we don't have enough dopamine. So by giving extra levodopa, we kind of force the system and we get a little bit more dopamine. So that's how it works in dopa responsive dystonia. Why does it work in other forms of dystonia? We don't know, and it's not really clear if it actually works. There's no studies that support that it actually works. And the mechanism behind it, it's not really clear because, as I said before, we think that we have in dystonia too much excitation and not enough inhibition, and dopamine in general is excitatory. So it's an excellent question. Why it works in other forms of dystonia is not proven whether it works, and we don't actually know why. But for dopa responsive dystonia, this is exactly why it works, because there's a lack of dopamine and we give extra levodopa to boost our level of dopamine. Is that clear?
I don't, there hasn't been a follow-up question, but the person who asked this question had said previously that her child, prior to being on this medication, couldn't crawl, couldn't do anything, and then after the fact was able to crawl, like he hadn't been able to until he started taking it.
Yeah, so that's an important, so it's the point I kind of wanted to make later on too, but genetic subtypes are really important in deciding which medications are better for us. Not these, not the trihexyphenidyl or the benzodiazepines, but more when we get to levodopa or DBS stimulation. So I'm not sure if this child has dopa responsive dystonia. That would absolutely explain why the child has improved so much. If the child doesn't have dopa responsive dystonia, as I said, some clinicians have experience that have anecdotally experienced that giving dopamine actually helps dystonia at large, not necessarily dopa responsive dystonia. I've personally, in a few patients, had some benefit to their dystonia, but it's never as striking as it is in dopa responsive dystonia. In dopa responsive dystonia, as I showed the girl before, people can literally go from being wheelchair bound to walking the next day. And that's not the next day. Sometimes it takes 2 or 3 weeks. And in other forms of dystonia, you don't get that overwhelming response.
Okay. We've had a bunch of questions that have come in. So we're clearly on the right track. I don't know, Dr. Meijer, do you want me to ask these questions? And you can let me know if you're going to be going into more detail later on, but I just want to make sure we don't lose them.
Yeah.
So the next question is, will you speak about side effects from Artane?
Yes.
Do you want to do that now or
it's coming in the next slide.
Okay. So. And then the next question is, how do you know what the best type of medication is if the neurologist will not do an updated MRI? Child is fit the typical causes of CP?
Say it again. If they don't want to do an updated MRI and the child has typical CP.
Does not fit the typical
all right.
cause of CP.
Yeah. Okay. So I'll answer that question now, I guess. So aside from having a genetic subtype of dystonia and certain medications working better for each genetic subtype, there is no real recipe which medication to start first. I tend to start trihexyphenidyl in most of my cases with dystonia first, because in children it's generally well tolerated. I'll talk about the side effects later, whereas benzodiazepines can often cause a little bit more drowsiness and hypotonia. The kids become a little bit more with low tone, and sometimes that's not desirable depending on what their neurological condition is, as a whole. So what I understand from the question from that parent is that the diagnosis is not clear because we're describing the child as atypical cerebral palsy. To me, that was actually my interest for my research project. When I was doing a fellowship, I was looking at atypical cerebral palsy children. And for me, an atypical cerebral palsy child is a child who worsens severely, significantly, and stepwise over time, and a child who has a normal MRI. So the first thing for this parent to see is the MRI completely normal? Yes, and is the child worsening? Well, then at that time, it'd be interesting to repeat the MRI. But if we have a suspicion that this is not normal, regular run-of-the-mill cerebral palsy, the best bet is not necessarily MRI, but rather genetic testing to try to see if maybe this child has a genetic subtype of dystonia. And then, depending on the genetic subtype, maybe there is a medication more suitable to that patient. For sure, if it's an atypical CP, I would recommend a dopamine trial, a Levodopa trial, to see if maybe this child is dopa responsive. So those would be the two questions that I would discuss with the treating neurologist.
Okay, thank you.
Any other questions, Stephanie, at this point?
Before you speak about artane and side effects, this parent had said that they did try a full Levodopa trial that didn't work. So I guess they're now moving on to artane, just so you have all the details.
Okay. All right.
That's all that we have for questions at this point.
Okay, good. I just want to mention also that it's really important for the Levodopa trial to be done for at least 2 or 3 weeks and at a good dose. Because often what I see in my clinic is that the children don't try it at a high enough dose because they don't tolerate it, and that we then say that there was no response. And it's really important, especially if there's no genetic workup done immediately, to really be sure of your Levodopa trial, that the clinician is really sure of his Levodopa trial. That's why I prefer always seeing my patients on Levodopa. I make them come back to see them again while they're on the medication and see if I see any improvement. But that's just kind of personal preference of mine. So I'll keep going, and I just want to bring back to this slide the fact that botulinum toxin is absolutely in this list, and I'm going to talk about it here. So when we as a clinician look at a patient, we divide it according to whether it's a childhood onset dystonia or an adult onset dystonia. In adult onset dystonia, we quickly go to the BONT is botulinum toxin when it's focal dystonia. So somebody with neck dystonia, hand dystonia, they get injected before actually trying the oral medications, because with the toxin, you don't have the side effects that the oral medications have. So if it's just one part and it requires only a few injections, that's the go-to treatment. As opposed to in children, where we often have to do diagnostic testing. And as I said, I do a Levodopa trial in all my patients. And depending on the diagnostic testing, depending on the genetics, which counts for the mom who just asked the question, which includes MRI, metabolic testing, if we fall onto a specific subtype, well, then you treat accordingly. So if it's a dopa-responsive dystonia, you give dopamine. If it's a vitamin E deficient dystonia, you give vitamin E. If it's biotinidase deficiency, you give biotin. And otherwise, First try levodopa and then all the other medications that I discussed. If the child, even though they have generalized dystonia, has one specific part of their body that's extremely dystonic, that's refractory to the medications, for example, a really bad hand posturing or neck posturing, we use in children also botulinum toxin to focally treat that particular problematic area. And then at the end in this diagram, there's surgery, which is deep brain stimulation or pallidotomy, which we'll talk about afterwards. And this is one way to approach it, but it's not necessarily always the case that surgery is the last resort. Sometimes we consider it a little bit earlier, depending on the diagnosis, the subtype of dystonia. So this is to answer the question for the moms about side effects. So I put this slide so that you kind of know what a typical dose range is for you. The artane side effects, most common, are blurry vision, kind of confusion, being less alert. Constipation and urinary retention are the big ones. I actually was just called for a patient who is severely constipated now, and we have to hospitalize him because of that. And dry mouth. Dry mouth can sometimes be a benefit because if your child has a lot of drooling, well, that helps with that. It's therefore really important when we start trihexyphenidyl artane to really keep an eye on stool frequency and urinary frequency to make sure that there's no changes. Compared to an adult, children tolerate high doses of artane. So we can go up to 40, 50, 60 milligrams in certain kids. An adult or on 10, 15 milligrams would start to feel a little bit kind of slow or confused. So generally in adults, we have to decrease the dose of artane. Benzodiazepines, I said the most common one that I use is clonazepam. Diazepam is Valium is the other one. And to give you an idea of the dose, the smaller pills are 0.5 milligrams. So we often start very slowly and then increase. The main side effect of this medication is drowsiness and fatigue. The children will sometimes be so tired they'll fall asleep in school or in their activities. With clonazepam, we have to monitor once a year liver enzymes. It's not very common and not a lot of doctors are aware of this side effect, but sometimes it can increase the liver enzymes. And this is a very important point when we'll talk about cannabis, because I will talk about cannabis. If we decide to add cannabis derivatives to clonazepam, we usually will have to decrease the clonazepam dose, not to cause too much drowsiness, first of all, and second of all, not to risk even higher liver enzyme increase. Carbidopa levodopa is really generally very well tolerated aside from nausea. It's really the nausea that makes it tricky. Some people are fatigued. Some people, their blood pressure becomes a little bit lower, so they're a little bit dizzy, but the main side effect is nausea. Tetrabenazine the main problem with tetrabenazine that we try to monitor is there's a black box warning for depression and suicidality. Higher in people who are already have depression symptoms, but it's something to definitely keep an eye out for when we start. And then in the GABA class, we have baclofen, which mainly causes lower tone drowsiness and fatigue. But the main issue with baclofen is often being too low tone. So after I've gone through these, are there any questions from the parents for the treatment? Because I know that this is the really important part for them.
Yeah, thank you. We had one question that asks, when you're doing a levodopa trial, do you prefer that the child is on no other medication? My child is on levodopa, but is also on several other medications. It is difficult to determine which is helping.
Yes. So ideally, yes, which is why in the diagram that I showed before, it's the first medication that I will try if a child comes to me for the first time. unfortunately, I often see people for the third, fourth, fifth opinion already. So they've already been on many, many other medications, and I can't just remove all of them. That's really a warning that I want to give to all patients, families, is that with these diseases and our medication, we need to go slowly. So we need to increase the dose slowly and then wean them off slowly. None of these medications we can stop from one day to the next really. If we're at a very low dose, yes, we can. But once they're already up on a therapeutic dose, they always have to be weaned off. And unfortunately, the best in the very severe children, we usually need a mix of all these different medications. And over time, it's really hard for parents to keep track of which one was really helping. So I sometimes try to wean off one if I really don't think that it's doing much anymore and the child is having a lot of side effects. But oftentimes it's a medication that the child has already been on for a year. So we really go and take it off slowly. But in terms of do we not know if the levodopa is actually helping because your child is on many other medications. If your child has levodopa responsive dystonia, you will know the difference. The child will improve dramatically. If your child doesn't have that type of dystonia, there might be tiny little improvements, and so I would recommend to introduce dopamine and look at its efficacy while keeping the other medications stable so that you know that whatever change is really due to the new medication, i.e. dopamine, that you just started.
Okay, thank you. Another question is, why is Artane less tolerated in adulthood?
Yeah, that's a great question. I don't necessarily know that answer. My hypothesis would be that the younger children either have more plasticity and can more easily adjust. And I think that their focus level that they need to do their daily tasks is less, it's just less tasking. So cognitively, they're less tasked. So the slowing, they don't notice as much, whereas the adults really notice. The other probable reason, which I don't know, is maybe children metabolize it very differently, because even the other side effects, constipation, urinary retention, children have them much less than adults. So I think it's also a metabolism difference. We know that children metabolize most drugs much faster than adults. But for Artane specifically, I don't actually know if anybody looked at that specifically, but clinically we know that definitely adults don't tolerate it as well as kids.
The final question that's come up, and you can let me know if you'd rather speak to it later. Mm-hmm. My child has acquired dystonia from CP. Mm-hmm. However, my mother has now been diagnosed with a rare form of Parkinson's. Would you recommend genetic testing to see if the dystonia is genetic versus acquired?
That's a really good question. I think it depends on, I would definitely talk to your child's neurologist about it. And what happens with the CP cases is that oftentimes they get diagnosed with CP at birth by a neurologist, by the neonatology team, and then they get transferred to a rehab facility and they're followed up by a rehab facility. And if they don't have seizures, they tend to not see a neurologist very often. Anyway, in my center here. So if you have that question, I absolutely recommend you make an appointment with your neurologist or find a neurologist to see your child again and say that you have this question. Bring all the documentation you can about the form of Parkinson's disease that your mother has, and talk to your doctor about that. It's a very interesting point because there's several articles right now that have shown that in the dopa responsive dystonia families, there are people who develop Parkinson's disease without actually ever having had dystonia early on, and they have the same gene mutation. So it's definitely something that is very interesting in research at the moment and that a lot of people are looking at. So I would gather as much information as I could about the Parkinson's disease that your family member has and go see a neurologist again.
The final question that's come in recently, and again, you may want to speak with this later, is for any parents that are outside of Quebec, if they were interested in seeing somebody in Quebec like yourself, How does that work? Is it possible or no?
Yeah, so I'll talk about it at the end. At the very end, I'm going to put up my email and the fax number for my clinic. And it is possible. In terms of insurance, we often see patients here for second opinions for all sorts of other diseases. We have a big neurofibromatosis clinic. We have all these specialty clinics for epilepsy, and we tend to see people for second opinions out of province. And it depends on whether your province covers second opinions out of province. Otherwise, we just charge a consultation fee.
Okay, great. That's it for questions right now.
All right, so I'll quickly keep going because it's almost DBS. I'll skip the research part, I think. So DBS therapy, I just wanted to, because there was a question about this. Basically, we implant electrodes here in the basal ganglia, and then they're connected with this wire, electrical wire, to the batteries, which are implanted in the chest. Okay, this is an older model where we have 2 batteries. There's newer models where there's just 1 battery and they're both connected to that. And the most recent technology are rechargeable batteries. It's not that recent, it's been around for a few years. So those are the options in terms of hardware. In an MRI here, where you see the side view like this of a patient's head, brain, you see the electrode coming into the basal ganglia. This is the trajectory that they implant the electrodes. The target of these electrodes are the bilateral globus pallidi, the GPI, and in some cases the thalamus. And how did we discover this? How does this work? Remains to be a question answered actually. But first data for this came from pallidotomy. So in the past, they, by accident or on purpose, this is a boy with severe generalized dystonia, and this is him after pallidotomy, where you basically burn a hole into the globus pallidus. So this is irreversible, the cells are damaged, and there was improvement. So they knew that this region was very important for dystonia, and somehow creating a lesion in this area would help. With DBS, it's much more refined. In fact, we create a lesion where the actual electrode goes in, but then we just stimulate with electrical shocks in this area, and it seems to also help. Exactly why this works, we don't exactly know, but we think that it has to do with the electrical stimuli seem to maybe have an effect on brain plasticity, so modulating the cells around it. The risks of DBS therapy, of this surgery, there's an infection rate. So sometimes we need to remove all of the hardware because they get infected. There's a bleeding risk, and the bleeding risk is very surgeon dependent. So it really depends on the track record of the surgeon. In one study that I cited here of Kaminska, it was 0.8%. So less than 1 out of 100 children and up to 3 out of 100 children. And these are mainly minor bleeds around the electrodes. It's notable also to say that the risk of adverse events in children is higher than in adults. And a lot of this has to do with the fact that children tend to get more accidents, they tend to fall more, so they break their electrodes, or they have more infections from scratching, etc. The latest review done very recently of 321 children in the literature who were followed up for a median of 12 months showed that 86 children had improvement of their dystonia. These are kids that were all comers, so with all different types of genetic dystonias. What so far has come out in the literature is that we think that certain genetic subtypes, which is why I keep talking about the genetic forms, respond better to DBS therapy than others. So I put a bunch of names here of genes that seem to respond well to DBS therapy. And in fact, for GNA01, the children are sometimes so severe that they get implanted at a very young age. Usually we try to implant after 7 years old because the growth of the skull, etc., is no longer very significant after that. But in the GNA01 kids, they've implanted them actually at a much younger age. We know that for ATP1A3, there's not very good results. There's data suggesting that the shorter disease duration you implant at, the better the outcome. So not wait until the symptoms get more severe. It can be used in status dystonica. Status dystonica is when the dystonia just suddenly gets so much worse and the child is just constantly posturing. In secondary dystonia, which includes CP, the results are less robust. And overall, there's very few very long-term data and quality of life data. And the hypothesis is that we actually think that overall quality of life improves with DBS, even if the actual motor scores don't improve. So in CP, there's 12 studies so far, and only 3 studies show a benefit. The age of implantation, the best candidates for implantation remains to be determined. So you can imagine that somebody with CP who has a lot of global basal ganglia damage might not be a good candidate because there's no good brain region to go stimulate in those children, for example. So these are all many studies that have been done, and you see overall all of the arrows down, these blocks down, this is 0, and so negative means improvement. All of the studies have shown improvement. So this is a patient of mine who had an ADCY5 mutation, and this is her before deep brain stimulation, and this is her after deep brain stimulation. You see even her face lights up, and this doesn't get picked up by the Berkshire-Marston scales that we use. This is really clinically, she was more awake, her face moved better, less hypotonic. We didn't make her perfect. She still has dystonia, she still has myoclonus, but she was much better. This is from another paper of children in dystonic storm. You can see very severe posturing in this child who's completely curled up, basically. And you'll see his after video shortly after. Again, this child was in extreme pain. So here you see he's still posturing quite a bit, but he's able to lie down flat and have more use of his arms. I'll skip forward to the next one. This is a very severe patient in a dystonic storm, as you can see, also completely folded up. And you'll see him after deep brain stimulation. I'm sorry if these images are disturbing, but there's no other way I can show this to you. So this is the same boy after stimulation. So it can be quite impressive, the results. But as my take-home message is that we need to select our candidates carefully. It's not a therapy that is necessarily appropriate for everyone. And this needs to be carefully discussed with the parents and a team of surgeons and neurologists. So medical cannabis, we only have a few minutes for a really hot topic, so I'll go quickly. There's 3 types of products available. There's THC, which is plant-derived. There's cannabidiol, which is oil, cannabis CBD oil, also plant-derived. And there's Nabilon, dronabinol, and side effects, which are synthetic ones. As you can see, the THC is CB1 and CB2 receptor agonists, so they stimulate these. CBD oil, on the other hand, has low affinity for CB1 and CB2, and it's rather maybe even an antagonist, so goes against. This is very important because how does medical cannabis work? We think it's a miracle drug. Everybody's very excited about the legalization in Canada, but really, what's the science behind it? So endocannabinoid systems are involved. It's a system that we have in our nervous system, a pathway, and it's involved in neurodevelopment, in cognition, in feeding behavior, in pain. And we know that these CB1 receptors are highly expressed in the brain, in the basal ganglia. So we propose that how it works in dystonia is that we increase GABA firing, which causes inhibition, and it decreases glutamatergic transmission, which causes excitation. What's known in dystonia, 2 small studies had shown that there was no effect in dystonia of synthetic cannabis. There's a small pediatric study that just came out in 2018 in an Israeli group. What's really important in this group to show is that these kids had complex movement disorders, including dystonia. 25 patients were enrolled, but only 15 completed the study, most likely because of the side effects. And they tried 2 doses of THC to CBD ratio, and they showed that those 2 ratios worked the same, and there was benefit to the children. The side effects are Immediate side effects are red eyes, euphoria, impaired short-term memory, dry mouth, hallucinations, increased heart rate, and appetite. On the long term, you can have, in the long run, you can have cyclical vomiting, restlessness, irritability, drowsiness, seizures, hepatic toxicity. So that's why I was talking about the combination with clonazepam. You have to watch for hepatic enzymes, liver enzymes. And we know that in children, there's studies that show that children perform less well if they consume cannabis products at a younger age. And the euphoria and hallucinations are mainly associated with the THC part. However, that seems to be the one that is the CB1 receptors seem to be the one that we need to target for dystonia. So that's basically it. So I'm going to skip the research part unless there's burning questions. And I'm just going to show you this one slide where one of the research avenues are ongoing clinical trials. So there's other medications that are currently being studied. People are studying DBS with alternative programming, with all sorts of different programming recipes. Transcranial magnetic stimulation is being studied right now, and the benefit of exercise in dystonia.
We've got a couple additional questions.
Yes, I'll just go to the conclusion slide. Yes, go ahead.
Okay, so there was a question about cannabis. How is it administered? Orally? Yeah. Like, is it pills?
Mm-hmm. Okay, so depending on what product you would have, the Sativex, for example, which is the synthetic molecule, is you can get it as a spray, as a puff. The cannabis oil, so what they use in the Israeli study is an oil, so you give orally. That's what we've been using in the epilepsy study that we're doing right now, which is also a study that has been done in sick kids. Those are the oils because those have the lowest content of THC. However, in epilepsy, it seems like it's the CBD that's helping for the epilepsy, whereas I'm concerned that mechanistically, the THC and the agonist of CB1 and 2 is what's necessary. So I have a feeling that for dystonia, we might need THC also, which gives the unwanted side effects.
Another question is, for a teenager who recently turned 18, has just been through a full Levodopa trial, 600 milligrams a day, about to start Artane tomorrow, what kind of mood changes, personality changes will we watch for, and how fast will these kind of side effects present?
Mm-hmm. So I assume that the doctor is going to start the medication very slowly. So sometimes 1 milligram 3 times a day, and then 2 milligrams 3 times a day, and they'll probably increase it to a total of 15 milligrams in a day and see what happens. Generally, the side effects would be after a week or so, you would start noticing. And I don't know if your child is verbal or not, but you just have to monitor really whether the stool and the urine stay steady. And in terms of hallucinations, you'll obviously notice an obvious change in your child. They'll mention that they're seeing things, or they'll be a little bit more confused. So it's just to monitor. But generally, the children do tolerate it well. It really depends also on how your child is baseline, which I don't know for the specific child, but.
Another question, sorry, I'm just whipping through them because of timing. And just so that you guys know, at 8:15, I think that the webinar will actually shut down. So if it does, if we do get cut off, we will send out presentations. There will be, an opportunity to see all of this without the videos online. The next question is, do you know what the success rate of DBS in truncal dystonia would be?
Mm-hmm. So that's a really good question. In general, truncal dystonia is a little bit harder to treat than the other forms of dystonia, but it really depends on the cause. So the 2 examples that I just showed had really bad truncal dystonia, and it responded beautifully, but they were all DIT1 dystonia, so torsin 1A mutations. So if I go back to my slide here, TOR1A is the one that responds the best to DBS so far. And GNAO1, KMT2B also. So DIT1 is torsin 1A. In DIT6, we have a bit less of a good response with truncal dystonia so far. But really, what I'm telling you now is really based on a very few cases, and there's a worldwide registry, actually a North American registry ongoing right now to better characterize and better keep tabs of everybody who's been implanted and how they're doing. Because in the literature, we tend to publish only the success stories, so we don't have a good grasp on exactly everybody who's been implanted and how they're doing. But that's what a registry right now is trying to understand.
Are there any mood changes seen in individuals with DBS?
Yes. So as a side effect of DBS, depending on when you get implanted, the person who programs you at the very first day of programmation, and it depends on whether the child is in dystonic storm or not, but let's say a child has regular dystonia and gets this. They, at the first day of programming, will go through all the different settings, or as many of settings that they can, to try to see at which stimulation there's unwanted side effects. So some people can become depressed, which is why in adults they'll do a full depression scale before considering you as a candidate for deep brain stimulation. And the other part is some people can get pseudobulbar affect, which means unprovoked laughing or crying if we get too close to the amygdala. So it depends on how close our stimulation is to zones that are important for mood. But generally with GPI, we have that much less because our electrodes are a little bit further away from those regions.
Okay, thank you. We have a few comments, Dr. Meijer, just saying that everybody's very grateful to you for your answers, so thank you. I think we have time for just a couple questions, and I have a few questions left. One is, we have had success with both CBD and THC oil. However, my child has been having vomiting episodes. The doctor believes this is because of reflux issues. What are the next steps? We would like to stop the vomiting. This is the first time I have considered that this is due to the cannabis oils.
Mm-hmm. So I personally am not very familiar with cannabis and dystonia. I'm starting to become a bit more familiar because we have a large epilepsy study going on here right now, and I want to start a registry and recruit children for this. Unfortunately, the one person I have experience with so far who's not doing well has actually become extremely irritable. So in the epilepsy group, we have a lot of irritability on CBD oil, even though their content of THC is very low. And I think that it's just trial and error. So if you have a suspicion that the vomiting is due to that, you would just have to try to decrease the dose slowly and see if it gets any better. But there's no other, to my knowledge, there's no other way to counter the nausea. In fact, at lower doses, cannabis is used in chemotherapy treatments to reduce the chemo-related nausea. But it's especially in long-term use that you can have, and it's been very well described in countries where marijuana became legal. At the emergency room, suddenly there were many more people presenting with uncontrolled nausea and vomiting in healthy individuals.
One final question. I think this question came when you were talking about research.
Mm-hmm.
What about cord blood and cord tissue, such as stem cell therapy from siblings?
Yeah. So right now, as far as I know, there's no stem cell study that shows that stem cells work for dystonia. It's very important to understand that, especially in the US, there's and in Mexico and in other countries, there's a lot of stem cell clinics that charge a lot of money for this unproven therapy. So I'm very firmly stand on the fact that right now I do not recommend any sort of stem cell therapy for children with dystonia, as there's no study that shows that it works. Will it be useful in the future? Is it useful to store cord blood from other children in the hopes of eventually being able to do some therapy? Maybe. Okay, but right now there's not enough data.
Okay. Thank you. I think we are out of time, and actually, I think that you have answered all of the questions that have come in. So, first of all, thank you so much, Dr. Meijer, for taking the time to do this. I know how busy you are, even just in us trying to schedule this and run through it. So thank you for your time. Thanks to all of our participants for being so active and for all of the great questions. And finally, just a thank you to the Allergan International Foundation who actually sponsored this event.
Absolutely. Thank you all for having me and for listening so attentively. These are all the people I have to thank that I trained with, as well as Dystonia, the DMRF, Dystonia Partage in Quebec, the patients and the families through whom I've learned so much. It's a wonderful opportunity. I thoroughly enjoy presenting to people and patients and their families. And if ever I need to do this again, I'll do it gladly. So start thinking about your topics that we would like to discuss in the future, and I'll try to do my best to answer your questions.
Thanks again. And to everybody participating today, please feel free to reach out to me if you do have specific needs, and we would happily put something together again in 2019. So
absolutely. And you see my email address, my work email address on the bottom of this slide, as well as the fax number. If any of you would like to come for a second opinion, I don't promise that I have any miracles to offer, but in case you feel the need, I will be accepting referrals from other provinces if so required.
Great. Thanks again. Thanks, everybody.
Thank you.
Bye.
Bye-bye.